So this next slide is showing the general setup for an electrocardiogram. So what is an electrocardiogram? Uh, it's 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 basically the electrical readout or the electrical activity of the heart that's then translated onto a piece of paper, and we view it in 12 different positions. So 12 leads. So we'll get a readout of 12 different positions on an ECG. And why do we want 12 different positions on an ECG? Because each one is a slightly different view of the heart. So we can get an anterior view in the front, a lateral view, which is on the left, left lateral, inferior, which is the underside of the heart. So this 12 lead setup allows us to view all these different positions of the patient's heart that can help us diagnose arrhythmias, which arrhythmia just means abnormal rhythm. So arrhythmia and dysrhythmia, don't get confused. They both mean the same thing, just an abnormal rhythm. So an ECG can allow us to diagnose what the abnormal rhythm is, and also an ECG can help us with diagnosing heart attacks, heart strain, ischemic heart disease, so a heart that is not receiving enough oxygen, such as in a condition called angina. We will get to these conditions as we go along. Don't need to memorize them all right now. So let's look at an electrical impulse starting at the SA node, which is where an impulse usually starts. So under normal healthy conditions, it's the sinoatrial node that starts the electrical impulse. Okay, and you should know the wiring of the heart, the fact that it goes from the SA node, spans across the atria to the AV node, bundle of His, then the right and left bundle branches, and then the Purkinje fibers. Okay, but now we're just looking at one electrical impulse that's going to travel down this nerve highway. So at the beginning, it's the SA node that sends out a little impulse. You can't see it on this because it's too tiny. It doesn't cause an electrical deflection. So the first deflection that you see is a P wave. And the P wave is depolarization of the atrium. Okay, so the P wave is just the electricity going over the P wave, over the atrium and depolarizing them, which will lead to a contraction of the atrium, of both of them, followed by a little break called the PR segment, which is where the electricity is being held up in the AV node just for a short period of time. There's a reason for it, but we won't get into it right now. Once the electricity is released from the AV node and sent down the bundle of His and the bundle branches, you get ventricular depolarization, which is your QRS. And that will lead to ventricular systole, or a systolic muscular contraction. And then you get to an ST segment. So there's nothing, it's basically isoelectric. There's nothing happening. Followed by the T wave, which is repolarization of the ventricles. Okay, so the ventricles are, when we say repolarizing, the sodium is being pumped back out, the potassium is being pumped back into the cells, calcium is being pumped out. So everything is getting ready for the next depolarization. Okay, and that is that is the part, if you look at what the heart was doing, is it's relaxing. It's in diastole, right? So think of it, there's two things happening at the same time. There's the electrical activity, and then there's the result of the electric activity, which is the contraction of the heart. And remember, the two atrium contract first, and then the two ventricles contract simultaneously together afterwards. So the electrical impulse leads to a mechanical contraction. So let's look just below here now. P wave is the depolarization of the atria, which then will lead to a atrial contraction of the muscle. A QRS is depolarization of the ventricles, which then leads to a ventricular contraction, and that's what we mentioned before is called systole. Ventricular contraction is systole, and that's going to come into play when we talk about blood pressure. Your systolic blood pressure and your diastolic blood pressure. We'll talk about that later. The T wave, as the ventricles are contracting, so they're in diastole, the electrical part of the heart is repolarizing and creating a T wave. So this slide on the amazing ECG is just to show you the general electrical rhythm of the heart. So this is actually sinus rhythm, and because it's originating at the sinus node, and I'll explain why. So before every QRS, which is the large deflection there, there's a small P wave. Okay, so the P wave is atrial depolarization, followed by an atrial contraction. The QRS, which is the large deflection, is the ventricular depolarization, followed by a T wave, which is the ventricular repolarization. And the whole rhythm repeats itself over and over again, so that the heart beats over and over again and regularly. So there's a P wave followed by a QRS followed by a T wave repetitively. Okay, and that's the rhythm that the vast majority of us that are younger are in. As we get older, we get into other rhythms, potentially, but this is the normal rhythm, normal sinus rhythm. Okay, so the whole idea is for the system to depolarize the atrium, then the ventricles, and then repolarize the atrium and the ventricles so that it's ready for the next electrical impulse. And why do we use an ECG? Now, remember, this is just one lead. This is just one strip. So on an ECG, we'll get 12 different views to look at the electrical activity of the heart. So you can imagine that we get ECGs and rhythm strips, such as this one, to look for arrhythmias. And arrhythmias are just abnormal rhythms. Another term for it is dysrhythmias, same term. We can diagnose heart attacks within the electrical activity that we see on an ECG. And we can diagnose many other conditions, and some that we'll get to as this module goes along. So there's one way. So typically you're given a 6-second rhythm strip. So if you're given a 6-second rhythm strip and you count the number of QRSs, the number of large deflections, then you should be able to calculate the heart rate. So let's look at this one. This is a 6-second rhythm strip, and there's 7 beats on it. So if you want to get to 60 seconds, which is a minute, multiply by 10. So then you have a 60-second rhythm strip. Multiply the number of beats by 10, which will be 70. So the heart rate on this rhythm strip is 70 beats per minute. So if you're ever asked to calculate the heart rate based on a 6-second rhythm strip, just multiply by 10 the number of QRSs that you see, and that will be the heart rate. Okay, so let's continue on and talking about the ECG. And before we talk about what's in this image, which is just a rhythm strip, this is just one strip. And remember, in ECG, we actually get 12 different views of the heart. And I'll show you an ECG on the next slide. But before looking at the ECG, we always want to know, what are the patient's symptoms, right? What's the vital signs of this patient? Do they have chest pain? Are they collapsing? So those are very important, even prior to looking at the ECG, okay? Knowing what's happening with the patient. So just to be a bit repetitious here, a normal ECG, the electricity begins in a pacemaker in the atrium called the SA node, and the P wave that we see on an ECG or a rhythm strip is atrial depolarization. Then the next deflection we see on a normal ECG or normal sinus rhythm is the QRS deflection, and that's ventricular depolarization. And lastly, the next wave is the T wave, and that is ventricular repolarization. And so it's PQRST, PQRST, and it just repeats itself over and over again. And that is really what's generating a heartbeat, right? That's what's causing your heart to beat. The atria first, followed by the ventricles. Okay, so let's just look at this this rhythm strip very briefly. So we're going to see here, we're not going to go into calculations or anything like that right now, but we're just going to ask ourselves a couple of questions. Is this fast, slow, or normal? Well, later on in another class, you're going to learn how to calculate the speed on a rhythm strip or on an ECG. This is definitely a slow rhythm. Okay, so this is bradycardic. Okay. Is it regular or irregular? And when we ask that question, we're looking at the QRS. Is the heart pumping in a regular fashion or in an irregular fashion? And if you were to calculate the distance between these QRSs, they would be exactly at the same distance, which is really a measurement of time. Okay? And lastly, are there P waves that are consistently before the QRS? So let's look at this rhythm strip now. Okay, so the first question is it fast or slow? Well, this is definitely slow. Are the QRSs regular or irregular? Well, these are perfectly regular. Are there P waves before the QRS? And the answer to that is, yeah, there's P waves before the QRS, but they don't have any regular distance before the QRS. They seem very haphazard in terms of how far away they are before the QRS. Okay, so if you were to take a ruler and measure these P waves, they would be perfectly lined up. So there's a P wave right to the left of the rhythm strip, or on the left-hand side. There's actually a P wave that's just at the end of the first QRS, and then just measure them, and you'll see that they measure up just perfectly. So this is telling us that the atria, or the SA node, which is where the automated beats are coming from in your heart, are delivering beats to the atria, causing atrial depolarization. but they're not being properly conducted to the ventricles. So there's a block there. And the ventricles are contracting, and we can see QRS beats here. But there's no regularity between the atria and the ventricles. So this is what we would call a third-degree heart block, where the atria and the ventricles are not communicating at all together. Okay, because typically the P wave should be followed by a QRS, which should be followed by a T wave. And this is not happening here at all. Okay, so not that we need to learn about third-degree heart blocks here, but I'm just trying to teach you what normal sinus rhythm is. And this is definitely not an example of normal sinus rhythm. Okay, the electricity that started as a P wave is not being conducted to generate a QRS. Okay, so you can ask, well, where are these QRSs coming from? Well, those are being generated in the ventricles themselves, because the heart has many safety mechanisms if there's a heart block. So say, for example, the atrium isn't delivering the electricity to the ventricles. Well, the ventricles can then generate their own heart rate. Okay, it's typically very slow, but there's a good chance that the patient will survive even with a slow heart rate until they can get a pacemaker. Okay, so let's have a look at this next slide, atrial fibrillation. So this is where this is an ECG, an electrocardiogram. So you'll notice that if you count, there's 12 leads starting at the top left, lead 1, going all the way to the bottom right, not including the rhythm strip at the bottom, to V6. And we're just getting different views of the heart. So time would be on the x-axis. And so time is on the x-axis, and we're just seeing the beats occur, or the electrical activity occur, in different leads of the heart. That's it. So let's look at this one briefly to see if we can figure out a couple of questions. So is it fast or slow? So the answer to this one will be that it's fast. If you were given a 6-second rhythm strip, this would calculate to be over 100 beats per minute, which would be a tachycardia. If it's less than 60 beats per minute, it's a bradycardia. Okay, so this is going to be a tachycardia of some kind. Okay, is it regular or irregular? So look at the bottom strip there. Are the QRSs right on time every time, or are they just unpredictably coming? One's coming a bit faster than the other, so the spaces between them are not perfectly regular. So this one's definitely irregular. And do you see clear P waves? Don't forget, sometimes you can confuse a T wave for a P wave. If you look in V4, you'll see that there's T waves that are clearly showing up after the QRS, but there's no P waves before. So if we look through these different leads, there's no clear P waves. Okay, so this is what's called atrial fibrillation. So basically what's happening is the atria are fibrillating, okay, and they're creating some electrical signals that end up at the AV node. And the AV node is allowing some of the signals to go through to create a QRS, but at an irregular rhythm. So atrial fibrillation, which you'll hear a lot going forward because it's a common rhythm in older people, is it can be fast, it can be a normal heart rate, it can be slow. it's always irregular, and there are never any P waves. Okay, so that's a good one to remember, because there's never P waves and it's always irregular. So what would we do with someone who comes in with this rhythm? Just very briefly. So it's fast, so we slow it down with certain drugs. And the types of drugs that we slow down this with are either beta blockers. If you haven't heard of these yet, don't worry. They'll start to make sense later. Or calcium channel blockers. A good example of a beta blocker would be metoprolol. A good example of a calcium channel blocker would be diltiazem. And so those drugs slow down the AV node. So they reduce conduction of electricity through the AV node, slowing down the electrical impulses that get to the ventricles, reducing the heart rate. So when we talk about heart rate, we're really talking about contraction of the ventricles, because that is what you're feeling as a pulse, which then we're calling a heartbeat. So it's always the ventricular systole that's creating the heartbeat. Now, you'll see at the bottom that we also use anticoagulants. So why do we use blood thinners in atrial fibrillation? Well, this is a rhythm where the top two chambers, the atria, are just fibrillating like little bags of worms. Okay? If the ventricles did that, there wouldn't be any cardiac output. You'd be unconscious. So ventricular fibrillation is a rhythm where you need to be defibrillated immediately. Otherwise, it's not survivable. Atrial fibrillation is totally different. It's when the atria are fibrillating, and then the impulses are irregularly getting through the AV node, and they're causing the ventricles to depolarize and contract. So this is not typically a deadly rhythm, atrial fibrillation. We use anticoagulants because when the atrium aren't contracting normally, and they're just fibrillating, there's a risk for forming blood clots in the atrium. If you form blood clots because the blood isn't flowing normally, and it's just sitting there, and the flow isn't continuous to the ventricles, if you form blood clots, you can throw off those blood clots, can then leave the heart during pumping and go to all kinds of different areas of the body. For example, if they go to the brain, they'll cause a stroke. If they go and make it down to a leg, they'll cause an ischemic leg, a blocked artery to a leg. So it just depends on where the blood clot, what's called the embolus, travels to from the heart. So atrial fibrillation puts you at risk for emboli leaving the heart. So we try to stop them from forming with anticoagulants. And lastly, we can cardiovert this this particular rhythm. So we can put paddles on the chest, we can sedate the person, and under certain circumstances, we can cardiovert them to try and change the rhythm back to sinus rhythm. Okay, so the first question is, why are we spending so much time on a rhythm called atrial fibrillation? Well, it's extremely common as people get into their 50s, 60s, 70s, and 80s. Very common rhythm to develop, and often some patients just remain in this rhythm. Okay, they often need treatment for it, but they end up staying in this rhythm. Other patients go in and out of this rhythm. It's not typically a deadly rhythm, but it's a rhythm that needs to be controlled with a variety of medications that we'll get into. Okay, so what causes atrial fibrillation? Well, I would say the first cause is age, right? As we get older, we can get some coronary artery disease, so some blockages to those arteries that feed the heart, and that can cause some disturbances of electrical conduction. So that would be the most common cause. If you have a history of congestive heart failure, you can develop atrial fibrillation very easily. So congestive heart failure is really a condition where the ventricles aren't pumping properly, and blood is backing up into the atrium. Okay, so let's use the left ventricle as an example. So the left ventricle is weak, it's not pumping properly, it's not getting all of its blood into the aorta, and so blood backs up into the left atrium and causes it to distend, to enlarge. And when you stretch the left atrium, it irritates the nerves of the atrium, leading to atrial fibrillation. Okay, very common cause. Certain cardiac surgeries can irritate the nerves as well, leading to atrial fibrillation. So there's a number of causes that can lead to this rhythm, old age being the most common. And really the underlying problem is that the atria have lost their ability to contract properly, because they're always just contracting very irregularly. So there's no predictability to their contractions, and they're not in sequence with the ventricles. So you lose what's called this atrial kick, which is the blood flowing properly from the atrium into the ventricles. So now, if someone presents in atrial fibrillation and their heart rate is, say, 190 beats per minute, well, they're probably going to be unstable. They're likely going to have a low blood pressure. They may have some chest pain. So those patients, we just cardiovert. So we take them to one of the trauma rooms, we put paddles on their chest, or pads, and we use what's called synchronized cardioversion. And synchronized just means that the electricity that they're going to receive is going to land exactly on the QRS. Okay, and there's a reason for that. You never want the electricity to land on a T wave. If electricity from a defibrillator lands on a T wave, you could put someone into ventricular fibrillation. So most of the time, if patients have a QRS, we use synchronized cardioversion. Okay. Now, if someone comes in and they're quite stable and their heart rate's beating at 150 beats per minute, but they're not having chest pain and their blood pressure is fine, we'll often just slow down the heart rate with certain medications that I mentioned before, such as calcium channel blockers that you'll learn about, or beta blockers that you'll learn about. We often end up putting patients on anticoagulants to keep their blood thin. If you can imagine, the left atrium is just fibrillating in atrial fibrillation. There's no coordinated contractions. The blood is going to become stagnant, and there's a risk for forming clots in the left atrium. And those clots can then travel from the left atrium to the left ventricle and then out into the systemic circulation, leading to, say, a stroke, right? So patients are on anticoagulants to prevent emboli if the patient has atrial fibrillation. And finally, cardioversion we spoke about. We can try and cardiovert someone if we don't want to keep them, or we don't want to have them stay in atrial fibrillation. Okay, so very common rhythm in older patients, and actually some younger patients in their 40s and 50s. Okay, so it's a good rhythm to understand.